The opinions and views expressed on this program do not reflect those of the management or staff of Community Media of Staten Island.
Hello and welcome to this edition of RUMC Vital Signs. Americans are living longer, and like a car, the longer we live, the more care we need, especially later in life. Joining me is Dr. Gottesman, Medical Director of Geriatric Primary Care at Richmond University Medical Center. Dr. Gottesman focuses on helping older adults maintain their health, independence, and quality of life through a more comprehensive, personalized approach to care. Doctor, thanks for being here.
Thank you for having me.
So, for viewers who may not be familiar, what exactly is geriatric medicine?
Geriatric medicine is the field of medicine which involves care to the older population. I use the word older sparingly. It doesn't mean elderly population. It doesn't mean exclusively the nursing home population. It doesn't mean the sick and frail. It really refers to the care of the population as individuals are aging. And we all age at different rates, and we all get older in different ways. Mm-hmm. And the geriatric medicine really is medicine which focuses on not just the medical aspects of care, but on the complete aging of individuals, aging well, and really living the best lives that people at this stage of their life can really live.
Mm-hmm. And what makes geriatric care different from what people may be used to with a traditional wellness visit or primary care?
That's a great question. General primary care and medicine in general has traditionally been thought of a field which focuses on problems. Patients mm-hmm. have heart problems, patients have thyroid problems, they have issues with their stomach. Patients can have a variety of medical problems, and medical care, as the term medical implies, has traditionally been focusing on the medical problems, the medical aspects of care. There's a medical problem, we will try to treat and try to address the medical issue, whether it's through pills, whether it's through types of medications, whether it's creams or ointments, but the traditional model has been focusing on problems, medical problems. Geriatric care really takes out the word medicine mm-hmm. from that care model, doesn't exclusively take out medicine, but it doesn't focus exclusively on it either. It's touching on medicine, but it's realizing that in order to address or treat the entire person, the medical aspects of their care are just one component of the overall issues that need to be addressed. So it's medicine plus.
Yeah. And so is there, what's the age, I'll say, that someone should consider geriatric care?
Yeah, I usually tell patients that they should consider geriatric care when they start to have a sense that their life is shifting. At different points in people's lives, people realize that their lives are starting to shift in a different direction, taking a different turn. It may be approaching or immediately after retirement. It may be at different points where they start to feel their bodies are changing. Frequently, patients will come and say, I feel like I'm slowing down, my body is different than it was 10 years ago. And frequently, patients realize that they're at a different stage in their life. And the model of care, which was provided to them and on their behalf for the significant part of their life, may not be the model of care which is best and more suitable for them at this stage in their life.
And when you say that a person feels a shift in there, is it different for men and women?
Not necessarily. It really is individualized. Mm-hmm. You would be quite surprised at how many individuals really are doing quite well and lead very active lives into their 70s and 80s and even beyond. However, for every individual, there's a different point in their life where they start to feel that there's something which is changing in their life. They're slowing down, their appetite's not the same, their energy level's not the same, their interests are not the same. Their social circle is starting to change. Their life in general is starting to change, and it may be impacting them on a physical or emotional basis. It may be impacting them on a psychological basis, and it can certainly impact their health as well.
And that's going to be a great segue into our next segment. And that really speaks to the idea of looking at the whole person, not just one issue at a time. There's actually a framework that helps guide geriatricians when examining someone. When we return, Dr. Gottesman will acquaint us with the 5 M's of geriatric care. Stay tuned.
Hi, I'm Steve Garvey, and I'm a prostate cancer survivor. But every year, 250,000 men are diagnosed with prostate cancer, and sadly, 35,000 or more die as it spreads to bones and vital organs. I'm saved because of early detection.
That's right, Steve. And besides being the #2 cancer killer of men, prostate cancer strikes black men at double the rate of the overall male population. We cannot allow this to continue.
Come on, guys. Stay in the game. For your family's sake, for your friends' sake, and for your sake.
Please, men, go to the doctor and have a discussion about prostate cancer. Early detection leads to the best outcomes. To learn more, go to fansforthecure.org. And thank you.
The 5 M's are a simple but powerful guide geriatricians use to focus on the most important aspects of a person's health and well-being. Dr. Gottesman, can you break down the 5 M's and why they are so important? Let's start with mind.
Sure. The 5 M's framework is essentially a model of geriatric care. Each one of the categories start with the letter M, which is where the terminology 5 M's comes with. The first M, as you mentioned, refers to the mind. And when we talk about the mind of the geriatric population, we're referring to all aspects of their mind and their cognitive state. We're referring to an evaluation for depression. We're talking about an evaluation for possible evidence of dementia, evidence perhaps of Alzheimer's disease and Alzheimer's dementia. Perhaps we're talking about patients who may have cognitive decline or signs of a cognitive decline, but not yet or nowhere near the stage of being demented. We're trying to understand their emotional well-being and their psychological well-being. Everything really stems from the mind. If the mind isn't healthy, no other aspect of that patient's life, quality of life, or any other aspect of their life can really be addressed appropriately or well unless the issues affecting the mind are completely understood and addressed to the fullest ability possible.
And the second one is mobility.
And mobility is critically important, although it's not considered a fancy or exciting part of medicine. Mobility, which of course ties into fall risk, is critically important. Falls are a major concern and a major issue which patients at times worry about, and whether patients have the ability to mobilize or to ambulate or to walk or just to get out and about is so fundamental for so many things. It's not simply a matter of their personal health in terms of their fall risk or can they fall, although we do significant assessments for patients' fall risk with formal testing of patients' fall risk. Having the inability to ambulate or to get out and about affects their social well-being. It affects their emotional well-being, certainly in the Northeast. During the winter, when the weather can be so harsh, if patients can't get out, that's critically important to their well-being and to their cognitive state as well. We also assess patients in terms of their footgear. I look at their shoes. Sometimes patients think that it may be something relating to their hips or their knees or their ankles, and sometimes it's simply that they're wearing inadequate shoes or sandals or footgear, which doesn't provide adequate support. So I look at patients' shoes as an example of how seriously we take this concept of mobility. So mobility is fundamental to the assessment of the geriatric patient.
And the next time is medications.
Yeah, I do a full review of patients' medications. Unfortunately, many patients are on a medication that they really don't need. They may have been started on a medication years ago and no one ever stopped it, and no one ever bothered to ask whether the original condition for which the patient was started on a medication is still relevant. And so they get medications added one on top of the other, and with each additional medication, the risk of side effects and adverse effects increases. And there's a medication cascade where patients may suffer side effects, and the side effect is viewed as a new condition. They're prescribed another medication to treat the side effect of medication A, which leads to side effect B from medication number 3. And we see this cascade, and there are patients who are literally on so many medications that the list runs 2 pages. So I do a complete assessment of patients' medications and the need for medications. That includes other things like vitamins. It includes herbal remedies. It includes homeopathic remedies. We talk about anything patients are taking and ingesting for their health.
So when you look at some medications, do you find that people who have been on a certain medicine may not have had any side effects when they were younger, when they first started, and now as they age, they are experiencing side effects?
Oh, absolutely. It's important to realize that as our bodies age, our ability to metabolize and break down medications changes with time as well. So what we may have tolerated years ago, we may no longer tolerate, but may not realize that it's the medication which seemed to sit well with us for so long no longer does, or the dose needs to be reduced, or the medication that we were prescribed by our cardiologist or by an endocrinologist or some other doctor is interacting with the first medication. So all of this needs to be assessed and considered when we talk about drug-drug interactions, especially in this population.
Mm-hmm. And the next M is matters most.
Yeah, matters most is really a fundamental concept and sometimes overlooked or underappreciated. When I talk about what matters most, the letter M for matters most, this is the 4th M in the 5M model, this is referring to what our patients' values, what matters to them. When we talk about what matters to them, it sounds like a philosophical concept. What matters to you, what matters to these patients, is really as we are aging, the potential for getting sick, of course, increases, the chance of hospitalization increases, and we're talking about things like having healthcare proxies, powers of attorney, really thinking about if when things go downhill, do we really know what we want to happen to our bodies, who is going to represent us in the hospital, healthcare setting, who is going to make decisions on our behalf, and are those decisions in concert with our personal value system. And this really is individualized based on a person's culture, religion, social values, and these can change over time as well. And unfortunately, it's usually after the fact when patients are hospitalized or they're too ill to make their own decisions, or talking about mind, the first M, and their mind is starting to wander and starting to go, and they've never expressed what their true wishes or values are, and suddenly family members are arguing, fighting as to what to do with mom or dad or grandma or whoever it may be, especially in the setting of critical illness.
I gotta be honest, I never would have associated that with healthcare, physical care, taking care of someone in that way. Do you find a level of resistance to some of that because you're talking in somewhat like end of life and people don't want to talk about things like that? So how do you find the hesitancy in that area? Yeah,
that's a great question. You know, talking about end of life, anything end of life can sometimes be a little bit awkward, can be depressing. Some people have this mentality, oh, we don't talk about that.
Right.
That's off the tables, don't go there, I don't want to talk about that. No one wants to talk about the end of life. But I'm very realistic with my patients. I had a conversation just last week with one of my patients, a couple in their 70s, and I raised this issue with them, and they said, you know, we never really thought about that. People go through their lives thinking they're going to live forever, and somehow things will just work themselves out. But these are the difficult and hard conversations that family members need to have with their entire family, certainly with their parents, and certainly with anyone who's reaching this stage where this becomes more of a reality. So it can be difficult, there can be a challenge in discussing these sensitive topics, but regardless, I find that it's my duty to do that, and if I don't, I feel that I'm not fulfilling my responsibility as a geriatric physician.
And the last M is multi-complexity.
Yeah, multi-complexity is a fancy word, which really reflects encompassing all aspects of the first 4 M's and putting it in context. So multi-complexity is taking all of these issues into account, but then also diluting it or really mixing it together with social determinants of health. What are patients' financial status? I'll ask patients about their sources of revenue. How are they paying their rent? Are they financially stable? I'll discuss with patients as well, and if they have family members, whether they have an estate plan. Do they have a will? Do they have a trust? Do they have all these issues in place? I had a conversation last week about patients asking what their burial plans were. Because we don't want families to get stuck with this after the fact. At the worst moment in time, families suddenly scramble when they're emotionally bereft and suddenly have to realize that, you know what, mom and dad never took care of these things. So pre-planning goes a long way. So I'll discuss things like that. I'll discuss things with patients regarding other aspects. What are their appetites like? Where are they getting their food sources from? What are their relationships with their other family members? Are they having conversations with their family on a regular basis? What's their relationship with their children or grandchildren or great-grandchildren? Do they have family support? It really is looking at the entire person, really trying to understand them. What is your life like? There's someone I saw on YouTube who draws portraits of people, and he finishes his portraits by saying, "This is a portrait of your life." And I'm really trying to draw a portrait of a patient's life, their complete life. And so by the time they get to the last M, they suddenly realize, you know what? I didn't realize doctors talk about this, or you're such an old-fashioned doctor. And this is what medicine should be like. And they appreciate the fact that I'm discussing topics which are really not purely medical, which no one usually discusses with them in a professional context.
So what drew you to geriatrics?
Yeah, that's a great question. Part of it is, the early part of my career was really based on more hospital or inpatient care. It was more exciting. It was more stimulating, perhaps. I think geriatrics are viewed by younger physicians as not as intellectually exciting or curious. Spending time with the geriatric population in general is not considered for many younger physicians to be as invigorating. And I think over time, as I've grown and matured myself in my medical practice and in my life, I've come to appreciate and realize that geriatric population is a grossly underserved population, and the need for geriatric care is massive. I find it very fulfilling when patients can sit and talk to you and can express themselves. I've had patients cry in my office because to some extent I'm providing them with the psychotherapy or outlet that they've always needed but never really had an outlet to express themselves. And I find it very fulfilling that at this point in my life, I can relate to some of these patients very differently than I could 20 years ago or even earlier than that. So I find it very fulfilling.
I think we're wonderful to have you. It's great to have you on the island doing services. Thank you.
You're very welcome. Thank you, Alex.
That really brings it together in a way that makes a lot of sense, focusing not just on treating illness, but supporting the whole person. When we come back, we'll debunk some geriatric misconceptions in our Myth or Fact segment.
Every day, signs warn us of danger, but often, hepatitis B won't give you a warning. Hepatitis B often doesn't cause symptoms. 1 in 12 Asian Americans is infected with hepatitis B, and most don't know it. It is not spread through air or by sharing food or utensils. If left untreated, it can lead to serious liver problems. Testing is the only way to know if you have hepatitis B. Talk to your doctor today about getting tested.
Dr. Gottesman has given us a great overview, but I think there's still a lot of misunderstanding out there about geriatrics. So let's clear that up in the Myth or Fact segment of our show. So I'll read a couple of myths or facts, a couple of statements. You tell if it's a myth or a fact, and then why. So the first one is, if you see a geriatrician, you have to stop seeing your primary care doctor.
That's a myth. You absolutely do not need to stop seeing your primary care physician. I can function both as a primary care physician, providing the services that we discussed and I outlined in the 5M model of care. At the same time, I can also provide services as a consultant to a primary care physician who may want me to do a more comprehensive evaluation of the geriatric patient. And again, my evaluations tend to be significantly longer than the time allotted for a general primary care physician. So my visits are usually an hour, if not longer, while the general primary care physician usually spends about 15 minutes per patient, if that much. So I can spend much longer time with the patients and understand what their issues are. And as I mentioned, really touch on the 5 M's to really comprehensively understand and evaluate the patients.
Myth or fact, caregivers and family members play an important role in geriatric care planning.
That is absolutely true. Family members and caregivers are so important to providing geriatric care. They're the ones who are living with the patient. They're the ones ensuring that patients are taking their medications. They're the ones ensuring patients are eating and drinking. They're the ones providing the care and can report back to me what is it really like for the patient in their home environment. And importantly, when patients come in with their caregivers, I assess the caregivers to fully understand the impact on the health of the caregivers and family members. If the caregivers and family members aren't taking care of themselves, and the patient won't be able to receive the best care possible either. So caregivers play an important role taking care of the patient, but they're also important for me to understand as well in this model of care.
Myth or fact, if you're still active and independent, you don't need to think about geriatric care?
That's a myth. At this stage in life, you always need to think about geriatric care. Now, whether you do anything about it or not is obviously up to the individual patient. But the topics that I raised, as far as understanding patients' cognitive baseline, understanding what their values are, what matters to them most, really understanding the social determinants of health, the multi-complexity, everything that we've touched on is important, and I try to plant the seeds for patients to think about the concepts and topics that I'm raising with them. Whether they act upon them immediately or not, to me is not necessarily as important as much as they think about the potential and really consider strongly about what to do moving forward.
Mm-hmm. Myth or fact, staying socially connected is an important part of staying healthy as we age?
Oh, absolutely. There's probably nothing more important than being socially connected. Being socially connected and physically active are probably the two most important elements to remain healthy in the geriatric stage of life. Not being socially connected has been associated with the equivalent of smoking 15 cigarettes a day.
Really?
Absolutely. Yeah, it's not that well known or not appreciated, but not being socially connected or feeling socially connected, and more importantly, you can be socially connected on paper, you can attend social clubs or religious services and be part of a social group, but still, perhaps you can still feel somewhat lonely. It's not fulfilling the emotional need that social connection can bring. Mm-hmm. So social connectedness is so critically important for every individual. What that means, how to define that, and what fulfills that need is very different, and I explore that extensively as well. But social connectivity is critically important. It's not just something good. It's a nice thing to have mom or dad connected with activities. It's critical for their health.
And I guess that ties into the mobility of M. If they can't get around and get out to be social, it has that impact on their health, I guess?
Oh, absolutely. Not being able to get out, being stuck in the house is, of course, very, very concerning for individuals who are stuck in the colder climates and literally sometimes can't get out of their house for days, if not weeks, at end. And that's so important to understand what it is that they're doing. I'll ask patients, describe your day to me from the time you get up in the morning. What do you do? Step by step by step. What is your day like in the winter? What is your day like in the summer? What are you doing to stay socially connected? And what can I do to assist you in that process?
And then our last question is myth or fact, a geriatrician can help coordinate care between different doctors and settings?
100%. A geriatrician can absolutely help coordinate care, can assist with care, can provide guidance to other physicians, and can certainly act as the coordinator of care at this stage in their lives. Many patients complain to me they feel like half their life or half their day certainly is spent just visiting doctors or planning on visiting doctors or making appointments. And I'll talk to them and I'll say, well, what's your quality of life if half your day is just spent either going to doctors, leaving doctors' offices, sitting in doctors' offices, or planning doctor office visits? And they tell me, you're right, my quality of life is not as good as it can be. So I will definitely attempt to assist them with the planning, assessing whether they truly need to even see their physicians that often. I'll reach out to their physicians to really inquire as to how often they truly need to see them, as opposed to there's a reflex, see me every 3 months. Whether they really need to see a doctor every 3 months. Is that really just a reflex appointment protocol, or is there some validity to the process?
Well, thank you for debunking some of those myths and facts.
It's my pleasure.
A lot of great insights there. I think what really stands out is that geriatric care isn't just about treating illness. It's about helping people stay independent, stay connected, and live well as they age. When we come back, we're going to take you inside one of the places where all of this is coming to life, our new Springville Center for Family Health and Specialty Services. Stay tuned.
I am blind, but I need not see. I know this road is there for me. If I'm really free.
Your life sounds pretty great. Don't let a buzz ruin it. Buzz driving is drunk driving.
Dr. Gottesman cares for patients at RUMC's newest facility, located at the Staten Island Mall in the New Springville section of Staten Island. So, appropriately, the center is named the New Springville Center for Family Health and Specialty Services. The center opened in December of 2025. Let's take a glimpse inside. Located at the Staten Island Mall near Barnes & Noble and next to Ulta Beauty, the center offers comprehensive healthcare services for Staten Island, all in one convenient location. The nearly 9,000 square foot center includes 10 exam rooms, an on-site lab with full services, and a spacious waiting lounge. The experienced medical professionals you'll find are among the best in their fields. Available services include geriatric care, primary care for the whole family, rheumatology, general pediatrics, pediatric endocrinology, and pediatric gastroenterology. Our center is walk-in friendly, so whether you're shopping and suddenly feel sick or need care without an appointment, our center welcomes walk-in patients for fast, accessible medical attention. So if you'd like to make an appointment with Dr. Gottesman for geriatric care, or make an appointment for any of the additional services provided at the New Springville Center, please call 718-818-5100. When we return, we'll wrap up this episode with some parting information on how you can partner with RUMC to make a difference in the health of your community.
How do you know when you've made the right decision? It's the feeling you get in your gut. The one that tells you what's right or wrong. It's the one that says, sure, I can have a drink. Or the feeling that says, okay, I've been drinking. Now what? It's the voice inside you that says, I'm buzzed. Better leave the car when it's time to go. Plan ahead. Catch a sober ride. Buzz driving is drunk driving.
I'd like to thank Dr. Aaron Gottesman for joining me today, and I hope you've learned more about how geriatric medicine is helping keep people healthy and active so they can continue living their very best lives. Once again, for additional information about our geriatric services and to make an appointment with Dr. Gottesman, you can call the New Springville Center for Family Health and Specialty Services at 718-818-5100. Richmond University Medical Center has cared for Staten Island for over 120 years. You can help ensure that care continues by making a financial contribution to the hospital. To donate, visit our website and click on the Donate button located at the top of the homepage, or you can call 718-818-2106. That just about does it for this episode of RUMC Vital Signs. Thanks for joining us. I'm Alex Lutz.
This program was produced through the facilities of Community Media of Staten Island.